consultants, and we have Mandy and Jack, our new sort of Parkinson specialists, who are both fantastic. I'm sure you will agree. There's a lot more to be done. And this is a very active branch because I work also in London. I see patients from all other areas, and not everybody is well served by their local association. So it's a really fantastic branch and a fantastic, fantastic work you all do. So Rose asked me to speak about new developments and treatments and those on the horizon. So it's quite a broad subject. So I'm going to put my hand up and say that I've incorporated my own biases into it, things that I think might be interesting. And it's very medical. I totally appreciate that Parkinson's disease goes beyond drugs and the medical aspects. There's social aspects, there are physical therapy aspects, there's all sorts of things that are equally important. So these are some of the topics I want to cover. There's a very large amount of stuff going on, some of which may come to something, much of which won't come to anything. So I've selected the things that I think have some promise in the near future. So just to show, like, if you go to PubMed, which is the database where we look at sort of scientific papers, it hasn't really come out, but there's something like 60. If you just look at Parkinson's disease, thinking that each page has probably about 10 or 20 references. There's 16,000 pages. So where to choose and what to talk about. And if you just look at treatment advances, that alone is 7,000 citations. So we have to be selective. The reason advances are important is that, I'm sure many of you here have Parkinson's and on a medication or several medications, but I can bet you that the vast majority are medications that have been around for at least 20 years. Often many of you on drugs have been around for 40 years or longer. And just to remind everyone, I mean, this is the original James Parkinson description, which is a really nice description in 1817. There were some references to conditions that probably were Parkinson's all the way back to, before the time of Christ, but this is the first time that this entity was described. And there's Charcot, is a very famous neurologist based in Paris, and he really sort of defined certain clinical features better. And these descriptions, they're from the 19th century, but they really sort of capture the essence of what you see with many patients, particularly those patients that have not yet been on treatment and who are struggling, the slowness of movement. They're able to do things, but it's just done in a much slower way, and everything feels more effortful. And really things got transformed in 1961. There was this discovery that Parkinson's disease was a lack of this chemical called dopamine in the brain, and it was this gentleman who first used L-Dopa, the drugs that many or most of you will be on, of those who have Parkinson's. And it was like a miracle, because before then people were trying brain surgery, putting holes in bits of people's brains, and this drug and people improved quite significantly. So this is, I just put this slide up. Not everything will happen to everyone. Some things may happen to some people, some things may happen to others. But it's a very complex condition. People present with tremor, slowness, stiffness. And some patients are really well on the medications, but others say, oh, my drugs don't work very well, or they don't last long enough, or they wear off. And then people may have other stuff like, start falling or may have some problems with their memory. And so it's a very complex condition. And when I see a patient with Parkinson's and they say, what's going to happen to me? I say, well, the variety, the spectrum of what's going to happen to you is as wide as the spectrum of the normal population. I've got patients who've been coming to me for over a decade and walk in and you can barely tell, and other patients who have a greater number of problems. So I think it's really difficult to say what's going to happen to an individual, but these are some of the problems that can happen to some people. And this is just a very complex slide, but all I wanted to bring to people's attention is that, when we first diagnose a woman with Parkinson's, we usually give either Cinemet or Maripar, sometimes drugs like Ropinirole or Pramipexole or Risagiline. We don't use Selegiline much anymore. It's quite straightforward, but then after a while, people may have some difficulties, and we have to chop and change and mix things up and add things to each other and change the timings because, the drugs may be variable in their effect, or they may have too much movement or too little movement. And then you get some patients where we really can't get good control of the drugs, and this is when people have these therapies. Deep brain stimulation is a way of treating Parkinson's where you can't get good control with medications. So these are what we call the advanced therapies. These are either continuous infusions under the skin, into the stomach. So this levodopa, carbidopa into stomach gel involves an operation with a tube going into the stomach. Deep brain stimulation involves brain surgery where they put electrodes into the brain. You have a battery pack inserted. And apomorphine infusion is an old Parkinson's drug that you can infuse under the skin. They're all sort of invasive treatments that come to it. Not everybody comes to this, so none of this applies to everyone. These are things that can happen to any one individual. So there's a lot of stuff where the treatments either become invasive or the management becomes difficult. So there's a real need for better treatments. And these are the drugs that people. We talked about Parkinson's being a lack of dopamine, or at least the movement symptoms. And levodopa, i.e. Cinemet or Maripar, that many of you will recognise, is probably the gold standard, and that was, as we saw before, was from 1961. So still the best drug. We have dopamine agonists like Ropinirole, Rotigotine, and then we have the mild drugs. So levodopa is the best, dopamine agonists are moderate in effect, and Risagiline is very mild. But as you can see, there's a whole bunch of side effects that can potentially happen, and this can limit how we're able to treat. And dopamine agonists, one of the classic things, particularly in very young patients, what we call impulse control disorders, where people can start gambling or shopping or become hypersexual, eat, or do all sorts of activities that lead to problems. These are some of the other drugs. These are usually add-ons, COMT inhibitors, like entacapone, tolcapone, apicapone. These act with levodopa to try and prolong and boost the action of levodopa. Anticholinergics. Most of you have never been on an anticholinergic, but we sometimes use it for tremor, but often has quite significant side effects. And amantadine has got very specific uses for when people have too much movement, what we call dyskinesias. So these are the unmet needs in terms of medical therapies. The medications are only symptomatic, so all the treatments we're giving are just to try and reduce your symptoms. They don't slow down or reverse any of the things that are going on in the brain. They may not treat non-motor symptoms. We taught that people might have constipation or sleep problems or depression, memory problems. The treatments aren't very good for those. We talked about some of them have side effects and some of them may be invasive. One of the challenges in trying to find new medications, first of all, it's a really slow process. We've got decades of trial after trial, things not working. what happens, it's like you set up a trial, it takes years, it doesn't work. Then you have to set up a trial from scratch again. One of my colleagues said it's like building a car, going on a journey, and you have to go on your next journey, but then you have to rebuild the car. You wouldn't do that. But this is what happens in clinical research. It's difficult. The placebo rate is very, very challenging in Parkinson's. So there's a very consistent placebo rate, partly because dopamine may be involved in reward and gain and other functions. But so we need to know that any therapy is better than just giving a placebo. And the placebo rate can be up to about a third of patients. If I just gave people a pill that have nothing in it, but they believe they're taking something, the placebo rate is quite high. Thirdly, patients, by the time they are diagnosed with Parkinson's, the process has probably been going on for 10, 20 years. How do we identify patients right at the beginning or before they've even had symptoms? Because that would be the window where if you wanted to stop the condition, you would do it before they had symptoms. And then the more thing is we don't know how to measure disease progression. There were a number of trials where we thought the drugs were altering the condition in the brain, but it just turns out they were acting in a symptomatic way, like levodopa was. And we don't have a really good way of measuring progression. If this was cancer, we could see that a lump had gone away or a lump it was growing, or if it was a kidney thing, we can measure the kidney function. With Parkinson's, it's very difficult to do that. So that's why the placebo rate is why we need rigorous clinical trials. And these are the stages of the clinical trial. You can see how long this all takes. In a phase 1 trial, you're just testing in a human, often in healthy volunteers, just to make sure it's safe. In phase 2, you may test it in the population of patients with that condition. So, if it was heart disease, someone with a heart problem. But in a small number to make sure that it does what we think it's supposed to be doing in those small numbers and that isn't causing a major problem. And it's really when we get to phase 3 where we have a large trial and it has to be against what we call a placebo, which is a dummy thing, and it has to be blinded so that both the patient and the person who is assessing you doesn't know whether you're on the pill or the placebo. And this process all takes a very long time. So one of the things that we're doing with my colleague, some of my colleagues, Professor Faltini at Green Square, Professor Camille Carroll in Plymouth, is doing what they've done in other fields, like the cancer fields, rather than just have one trial against placebo and then reconstruct the trial for the next thing. There's this entity called a multi-arm trial, and what you have is a placebo running, and then new treatments can just add on, and then when things are looking promising, they continue to the next phase. When things don't look promising or cause side effects, they drop off, and new things add on. So it means that you have trials in parallel. And if you think about prostate cancer, for example, they've had a similar approach, and about 5 new treatments have been identified using this methodology. So that's a new approach, and this is a big undertaking with about 80 of us all involved in different aspects of trying to make this work. The other thing that could be useful with these challenges is repurposing drugs. If you've got a new drug and you have to do all the safety testing, what about a drug that we already know is safe? It's being used for heart disease or there are drugs that may have more than one function. In neurology, we see it all the time. You give a drug for epilepsy. A drug for epilepsy might be used to treat migraine, for example. So what about drugs that are already known about where we have safety data? That would save a lot of time. So when we come to the unmet needs, we talk about motor fluctuations, which some patients may be familiar with. When they start taking medications, they feel that the response to medications, the medications may work, but they might not last long enough, or they may not work every time, or they may be really stiff in the morning, or they may have too much movement, what we call dyskinesias, where the levodopa concentration is too high for you. And these are some of the problems, and these are some of the non-motor features that happen in some. Not some people may have some of them. Not everybody has them, but these are some of the things that can happen to some people, and these don't tend to be affected by dopamine drugs. We may need to give different treatments for depression or bladder problems or constipation or sleep problems or pain. So these are not really well addressed, and this is another one of these things. And then there are also some movement symptoms that don't respond very well to drugs. People may say they have balance problems, and drugs can help in some patients, but in many patients they won't. Freezing of gait when you try to walk and then you just can't have a forward motion. You're making the stepping movements, and you can get stuck, particularly when going through doorways. Now, things like this may not always respond optimally to medications. And then we talked about the need for drugs that may actually not just help symptoms, but help the underlying process. And I would divide these into neuroprotection and neurorestoration. So neuroprotection is what you give to protect your nerve cells so that no more die and no more the disease progresses. And neurorestoration is trying to give back something you've lost. So neurorestoration is like trying to replenish. It's like putting some fertilizer on your garden, trying to get things to grow back. Whereas neuroprotection is putting something to stop the grass from dying. So and there've been a number of these agents that have tried, and lots of different scientific mechanisms. Neurorestoration, there've been gene therapies, which just fortunately haven't really shown any promises, where you transplant cells that secrete these growth factors like a fertilizer for the brain. And that's been attempted. These neurorestorative techniques haven't really been helpful so far, although we will come to something that is in the pipeline. So I'm just going to talk briefly about some of the drugs that have been, new drugs that have been licensed for PD around the world, and focus on the two that have been licensed in the UK. It's very interesting, the licensing. There are some drugs we've had for ages here that have only just had licensed in the States, and stuff that have been in the States that's not here, and why that is, or whether there's some lobbying or vested interest or what it is, it's difficult to say. But there's some variation between countries. The two that have come out in the last decade in the UK are safinamide, which is a bit like it's a bit like a mixture of rasagiline, which is a very mild PD drug that stops your dopamine from being broken down, but also works on this chemical glutamate, which is a bit more like amantadine, which is also used for dyskinesias. And opicapone is a bit like entacapone, which boosts your levodopa, but it's much more potent than entacapone. And then there are others. The one that I think's I wish we had in the UK is the pimavanserin, which is for patients who become, a small proportion of patients with PD may develop psychotic symptoms, and that shows a lot of promise. But these are some of the other drugs that are available in other countries. So 2016, I mean, when I think about it, it's the first time since I became a consultant that a new drug was launched for PD. And this is opicapone. This is the COMT inhibitor, the drug that boosts levodopa. And I just wanted to explain this curve, you see. So what happens when you take L-DOPA? L-DOPA, as many of you will know, you take it several times a day because it doesn't last long in your system. So when you so when you take L-DOPA, particularly when you've had the condition for a few years only, it goes up in your system and then goes down, goes up, and that's what you're doing. When you're taking it 3 or 4 times a day, it's going up and going down. But what happens is, as you've had the condition for longer, this is the bar that's needed to get rid of your symptoms. This is the bar where if you go over it, you get too much movement. What happens as the condition progresses is that this bar goes up and this bar comes down. So what happens is that you can take the drug and it takes a while for your symptoms to go. Then the symptoms might improve, but then it may overshoot this line. You may have too much movement, what we call the dyskinesias, and then they come down and then you're off again. And so what you have is what we call on-off fluctuations. So the drugs they may not work for very long, it'll take a while to start working. When they work, you might have too much movement. So what the picapone does is it boosts levodopa. So think about the last curve, all these troughs were down here. It just lifts everything up. So what you're doing is trying to increase the time that you're in this space where your symptoms are relieved. The problem with it is that it increases the peak as well. So you may get more dyskinesias, and then what happens is that you may then need to reduce your dose of levodopa so that your baseline is above this, but the peak isn't so high. And you can see that these are the other older drugs in this class. This is much more potent, and this is what we see clinically. We see a proportion of patients who respond fantastically well. I had a patient who was taking the drugs every 2 hours, and then she was put on this and only needed it 3 times a day, every 4 or 5 hours. So it can be as potent as that. The problem with it is because it's very potent, there's quite a significant number of patients who don't tolerate it because the peak of your drug is so high. There are people who can get dyskinesias, the writhing, fidgety movements, but also you can get what we find is we get some people who are a bit wired, they've got so much dopamine that they're a bit jittery or their behaviour can go up. So I'd say about a third of patients that we have respond really well to it, a third respond so-so, and a third really it does not good. It's not good, and we have to stop it. This is the other new drug, safinamide. This is this is a monoamine oxidase inhibitor. So monoamine oxidase stops the breakdown of your dopamine. So safinamide stops the breakdown of your dopamine. So it's like it's squeezing out more juice from the dopamine that you have in your system. But it also has this. It's a dirty drug, so it has other effects on these things. And for that reason, it also may have some effect on dyskinesia. So when you see people, sometimes we don't use it a whole lot actually, hardly ever in fact. But in some patients where we're really struggling because there's a lot of off time and some dyskinesias, we might use it in that situation. And this is just a curve from the study that was done, which showed that this is on time. On is when you're good and the drugs are working. And you can see these are people with placebo, and these are people on the drugs. You can see that there was an improvement. And this is Tony Shapiro, who works with us and actually was my boss once upon a time when I was much younger. And it was his study that showed that, on average, there is some modest effect in improving your on time, i.e. the time when you're good. So as I said, I just talked a little bit about possible disease-modifying therapies, neuroprotective, neurorestorative, and just to show that there have been a number of drugs. In fact, all the drugs that everyone takes have all been subject to trials trying to see if it modifies disease, like levodopa and ropinirole and all these drugs, and none of them do. And there have been quite a number of studies trying to find agents that may alter the underlying condition. I wanted to, as many patients have asked me about this, it's very topical, and this is the cough medicine, Ambroxol. And what Ambroxol, well, we'll talk about what Ambroxol does, but there's a trial that's in development for this, and could this humble cough medicine be a possible breakthrough in treating Parkinson's, in treating it as in a way that alters the underlying pathology in the brain. This is just a bit of a complicated slide, but I just wanted to bring you to the history of this. There's a condition called Gaucher's disease, and this is caused by a genetic defect in a gene called the GBA gene. And this affects children. It's a very severe, awful disease, and they have two abnormalities in the GBA gene. And what the pediatrician observed is a lot of the patients, parents that came to the clinic with these kids, seemed to have Parkinson's. And if you think that these children would have got one gene from their mom, one gene from their dad, it seemed led to an area of exploration. And we found that having one of these genes is probably the commonest risk factor for developing Parkinson's. Which was interesting to see. So this is the GBA gene, and the reason Ambroxol came, so what GBA does is it produces an enzyme called GCase. And what GCase does is clear this protein called alpha-synuclein. Now alpha-synuclein is what clogs up the cells in your brain and causes them to die. And what GCase does is it clears this from the brain. So if you have not functioning GCase, this goes up and accumulates. It's like a seesaw. So the more GCase you have, the lower alpha-synuclein, and the less GCase, the more alpha-synuclein. So these patients with these GBA mutations who have low GCase have an accumulation of alpha-synuclein. And what they did is a drug screen for these patients, for these children with this, tested just thousands of compounds to see does anything affect GCase, and that's how they identified Ambroxol, this humble cough medicine. It seems to have an effect on reducing this, elevating GCase activity. And the interesting thing is, it's not just patients with this gene defect have reduced GCase. Patients with PD without this mutation, bog standard PD, have reduced GCase in the brain. So that's why there's real promise and hope that Ambroxol, a tablet, a humble cough medicine, may elevate GCase and reduce this in the brain and reduce toxicity and reduce pathology in the brain. And there were some phase 2 trials of Ambroxol, which in the phase 2 trial, if you think, is in patients with the condition, small numbers, just to see that it works in the way it's supposed to. We could see that it does penetrate the brain and it does increase the GCase enzyme levels. So this is the trial that I think, I've had a lot of patients ask me about this. It's one of the ones that is being done with Cure Parkinson's Trust, and this is the trial, and they're currently developing the trial, but also currently trying to recruit interested patients. And this is going to be a 2-year trial where you either have Ambroxol or a placebo, but then at the end of 2 years, everyone will receive Ambroxol. So that's one of the things of great interest. Another drug is exenatide. Exenatide is a diabetes drug, and this is a classic example of repurposing drugs, not reinventing the wheel, something from scratch. This is a known drug that has been used by diabetologists for many years. And what it seems to do is it seems to, in animal models, it seems to penetrate the blood and inhibit this protein and reduce brain pathology. And what we could see in a trial in 2017 is these patients, this was a brief trial, it was only 48 weeks, and then after 12 weeks everyone came off everything just to reduce any chance that it was just helping the symptoms. And what you could see is that in this very small number of patients, even after the drug had been stopped, they were better than the patients who hadn't had exenatide. So this is a suggestion that this drug might be having some effect on the brain. So this is a trial. This has now gone to a phase 3 trial, multi-center, much bigger trial where it will be taken for 2 years. I put this on because I think this is, out of all the disease-modifying drugs, is the one that is showing the most promise so far. I think the trial's ongoing, but they're fully recruited to that trial. Stem cells, a lot of patients ask me about stem cell therapy. And a stem cell is so if you think about the various bits of our body, our heart, our skin, our bones, they're all, if you look at it, they're all different, the cells, but they all come from stem cells. A stem cell is a cell which can turn into any other type of cell in the body. And when it becomes, say, a bone cell or a liver cell, that's what we call a differentiated cell. So you can see here, stem cell can become a blood cell, bone cell, muscle cell. And what's really interesting now is that we can now engineer stem cells in a dish to become a muscle cell or a brain cell or a dopamine cell. So this is really exciting because it means that we talk about neurorestorative. Can we replenish some of the lost nerve cells? And this is quite exciting. And the other exciting thing is that all the arrows are going from the stem cell to the differentiated cells. So there's now technology where you can take a differentiated cell and reverse it back into a stem cell and then make it into some other cell. Right? So that technology exists. So there's technology where you could take a skin biopsy from someone, turn those skin cells back into a stem cell and then turn it into a dopamine nerve cell. So there's a lot of excitement about this. There are a lot of technical challenges. If we do this, will they survive in the brain? Will they form connections? Will they improve outcomes? But this is a trial, so this is a really exciting thing. You can look up STEM PD, any patients, but it's being hosted from Cambridge by Professor Roger Barker, but there are centres, there's going to be centres all around the country where essentially this is going to be the first time they produce cells that are actually derived from embryonic stem cells, so they're not from your skin or anything, embryonic stem cells, turned into dopamine nerve cells and will be transplanted into people's brains. And this is right at the beginning of this process, and what they're trying to do is determine whether A, it's safe, whether it forms connections, and B, and C, whether it, in these initial studies, shows any effect on your sort of clinical symptoms. So this I think is a really exciting thing that I've picked out, and something that interested patients may have access to. This is just to say this is a phase 1 trial that I'm one of the investigators for in London. Where this is a compound which is designed to try and limit inflammation in the brain. So inflammation is what happens when we cut ourselves or burn ourselves, everything becomes red and angry. There's a lot of inflammation in the PD brain. And this compound is targets a certain protein in the cell that reduces inflammation. And this is really like the stem cell trial right at the beginning. The trial is for people who've had PD, early PD within 3 years of diagnosis, to see whether it has that desired effect. So that's another thing, and that's a multi-center global trial across North America and Europe. So I just wanted to, those are the three I've selected for disease modification. What about the things, we talked about when things get really difficult to manage, people might have deep brain stimulation or a pump into their stomach or into their skin. Are there any things that might be a bit more palatable than having a tube put in your tummy and things stuck in your head? So I just looked through, these are drugs that have gone through phase 3 process, so they're probably going to be licensed. So this is subcutaneous, well, it's false levodopa, false carbidopa. So it's like levodopa, but it's a modification that converts into levodopa. And this essentially is like L-dopa, but if you're getting a lot of the fluctuations going up and down, you can just go into a little thing under your skin and continuously infuse. And this is just their phase 3 trial, which shows that their on time, probably tripled in this patient group, and their off time was significantly reduced. This is essentially like duodopa, the thing that you put where you put a tube in your stomach and you have continuous levodopa. But that involves you having a small procedure and having a tube like a stoma, essentially, in your abdomen. And this is much less invasive. There is another type of this subcutaneous levodopa, carbidopa, which is going through the phase 3 process and has just been in the phase 2, i.e. small numbers of patients. So this may be another option going forward. So there may be another treatment in the advanced therapies in addition to deep brain stimulation and these other invasive infusions. So apomorphine, apomorphine is a really old drug, and we often use it in patients who suddenly switch off, and they get stuck. They're out about time. It's really disabling because patients become fearful of going out. What if you're caught short? You suddenly switch off and you can't do anything. And so we found a very old drug that goes back years and years where someone has a pen. It's like having insulin. You just sort of jab yourself, and then within 10 minutes you may switch on again. But again, it's not the most appealing thing, having to stick a needle into yourself. So there is a phase 3 study of apomorphine, which you put under the tongue. And that, I think, is very likely that this is going to be licensed, but it's still not licensed yet. But the phase 3 study is it's very promising. So if you look here, when you take the sublingual apomorphine with someone who's off, there's a really big improvement, and the placebo just stays like that, basically. Just wanted to mention this. I don't know if anyone's had deep brain stimulation, but where people have advanced Parkinson's in terms of not being able to control their treatment, people may have brain surgery where they have electrodes in the brain connected to a battery pack. There's the alternative, and what used to happen before deep brain stimulation, is that people may have open surgery and have a hole burnt in that bit of the brain. So the open brain surgery, what we call a pallidotomy. Now there's a technology where, and there are two in London, one at Imperial and one at Green Square, the National Hospital, where you go in an MRI scanner and you have like 5,000 high intensity ultrasound beams, which all converge on a single point, which is like a millimetre or sub-millimetre point. And only at the point where they all converge, a tiny little hole will be created to sort of block, to create a block in that pathway where you would have before had to have had open brain surgery. And so this is what we call incisionless surgery. So this is now licensed in this country for non-PD type of tremor, what we call essential tremor. But I'm pretty certain this is coming to Parkinson's. So tremor in Parkinson's may respond to drugs, but it may be the symptom that in some patients does not respond to drugs, and the only thing that may control it is an operation to block the tremor. And this may well be a good option. And this is the trial that led to it being licensed in the US, which basically so the good thing about focused ultrasound is that you can actually do a placebo. You can do ultrasound. You can give ultrasound beams, but not at the intensity that burns a hole. And so you can do a placebo. In the old surgical trials, for example, with fetal cell cancer, some very sporting individuals would have a neurosurgical operation, but it would be placebo. But this avoids the need for that. But what you can see is the tremor scores are much better in those people with focused ultrasound. So I think this is going to have a role for patients who have tremor, particularly where it doesn't respond very well to drugs, and the licensing will follow. At the moment, there are only 3 centres in the UK that do this, 2 in London and 1 in Liverpool. But Imperial College in London, where it was first, brought through in this country, a waiting list of like a really long waiting list, and so the demand is definitely going to be there, and I'm sure it's going to be something that's more widespread. It's a fairly new technology. So that's just a snapshot of some of the things that I think are going on. As I said, my hands up, my total bias is towards the sort of medical side of PD. There's a much wider set of issues that one can talk about. But I just wanted to raise some of these things to say that I think that after 2 or 3 decades of stuff that either new stuff not coming out or it was just a bit more of the same, I think we are on the cusp of a lot of new and exciting things here. And obviously that's sort of that hope that things that are always on an upward trajectory is something really important to to keep hold of, I think. And I think I'll end there. Thank you very much for your attention, and I don't know if anyone wants to ask any questions.
Well, that was going to be the next question. It's,
Can I thank you on behalf of everybody very much indeed for a talk. I'm sure a lot of the information was known by some, certainly none of it is known by me whatsoever. But has anybody any questions of Dr. Korlipara at all? Anyone would like to come in with anything at all? Yeah, Rose over there.
So the things that are on the 2 phase 3 trials that you mentioned, so exenatide and also the subcutaneous levodopa, both in phase 3 trials, I think, and they both sound very exciting. But when do you think we'd actually see them being licensed? When would be your guess?
Well, exenatide is still in the phase 3 process. I think that subcutaneous levodopa, I think within the next couple of years would be my would be my guess, because that has already, the false levodopa, the other one, there were two, the other one's still in phase 3, doing it in the phase 3 process. But interestingly, NICE can do reviews of things before they're even licensed, and they have done a review of the subcutaneous levodopa, so, or they produced some initial documents, which I'm hoping is a sign that it's not too far away.
And when you say it's still in the phase 3 trial, that means you just can't guess when it might be licensed?
Well, for example, exenatide is, it's a 2-year study. The patients that are in it are in the middle of that. And then after that, the data needs to be analysed and put up for scrutiny, and so I think exenatide probably, I'd say within 5 years, if it shows the promise. What some patients do, because it's not licensed for PD, but it is licensed for diabetes. So if you're unlucky enough to have diabetes and PD, there are some patients who ask their diabetologist whether exenatide is a treatment that they can have for their diabetes. And I do know some patients who are just getting ambroxol themselves as well. So.
Thank you.
Thank you, Ruth.
Yeah.
Anybody else would like to ask a question? David? Christine would like to ask a question. David? Sorry, Christine, next time.
Okay. No, over the other side.
David? Christine here.
Just a quick question. Is there any evidence that the inflammation that we have with Parkinson, I know that it starts in the gut, is there any evidence about harsh arrhythmias being caused by a similar type of thing?
In patients with Parkinson's?
In patients with Parkinson's, yeah.
I don't think there's, to my knowledge, I don't think there is any evidence of increased arrhythmias in PD. There is evidence that the heart may get denervated, so there's something called the autonomic nervous system. The autonomic nervous system is the nervous system that controls our unconscious bodily functions, like our heart rate, blood pressure, So some people can, when you do a certain type of scan called a cardiac MIBG scan, you can see that the autonomic nerve supply to the heart is impaired in some patients. And and what you also see is that there are some cardiovascular autonomic impairments. That's why some people can go very dizzy when they stand up or have very low blood pressures, that kind of thing. But actual arrhythmias, I haven't come across any evidence, and it's certainly not been my observation with my patients.
Thank you.
Over the stem cell treatment, you have to take any drugs to reduce your immunity. Is it stem cells from another donor, or is it your own stem cells?
No, they're from a human embryonic stem cell, so you need to take some anti-rejection drugs. The aim ultimately, if these things work, is for us to be able to take a piece of your own skin, so there's no incompatibility, put it in a dish, turn it into nerve cells eventually, and then put it back into you. So that would be the end point that people would, but there's a lot of steps required for that. This stem cell thing is not a new thing. Interestingly, before I even graduated at medical school, there were lots of trials. I think late 80s and early 90s of transplants, but they were from fetal dopamine cells, not stem cells, from fetuses, and so what happened is that this showed some initial promise, and then it went to 2 large randomized controlled trials where, as I said, some people actually had a sham neurosurgical procedure as a placebo. And what happened is that a proportion of the patients, about a third, had these severe wild involuntary movements, which completely completely ended the field for nearly 2 decades. But interestingly, there was some even in a failed trial, there were some messages, because there were some patients who did amazingly well. In fact, there's a patient at Queen Square who was on no drugs nearly 2 decades later. So there was something, and it was a very dirty trial, because there was just a collection of cells from the fetus rather than a pure population. So, techniques have improved, tried to identify those patients that may respond. So things evolved, but there were some patients who did dramatically well with that treatment, but because of the trial results, it just, the field ended until the sort of stem cell revolution came back on board.
David?
When you say early and mid-late,
Yeah.
what is the range of early? What, in the number of years, when you say someone's in early stages or mid-stage or late stage?
Well, I would say that that's hard to define, but what I would say is that when you diagnose someone with PD and you put them on medications and they ask, what's going to happen to me? I mean, generally, on average, and you can't really extrapolate from a whole population to a single individual, all you can say is, if you had 100 people, this is what would happen to the vast majority. But I would say that once you find the treatment that's right for you, people generally remain well for at least 5 years. And it's not to say you won't remain well after 5 years. It's just difficult at time 0 to say whether you will after 5 years. But I've had patients who've remained well for much longer than that. And as I said, so early, if you're pitting me to a number, I would say within 5 years probably. But people may be exactly the same after 5 years as they are in that early phase. So when I refer to early mid, I'm talking more in some ways I'm talking more about the state they're in, the patients who are just doing well and stable, time after time say I'm doing really well, whereas mid is when I guess they're running into a bit of trouble with their medications, needing more fine-tuning and adjustments, and then beyond that is when people need the advanced therapies or struggling with things that the drugs aren't touching. So that's how I conceptualise it.
Anybody else like to ask a question, Dr. Korlipara?
Sorry, no, I'd agree.
Christine's back in again. David?
Which goes it?
Now to Christine again.
Sorry, I just want to hold the microphone. So, in terms of early, mid and late, are you an advocate for exercise helping people to keep their symptoms under control by doing lots of exercise?
Oh, completely. And actually, I thought that I would I'm always telling my patients to exercise, and I partly driven by we needed to get to the tube because of the rail strike. I brought a folding bike today, but it's interesting that cycling, is one of the things that patients who have struggled with everything else seem to be able to do. But exercise is probably the only disease-modifying agent we have in Parkinson's. It's difficult, and we see it in lots of animal models that it seems to have a disease-modifying effect. It's difficult to categorically prove, but I'm pretty sure that it's the only disease-modifying agent. None of the drugs are. So it's the thing that I absolutely tell all my patients to do. And they often ask which exercise. And obviously there are really good exercise classes, and there's the PD Warrior. But I think the most important thing is to do something that you enjoy. Because like everything, whether it's various diets or anything, you're not going to keep it up unless it's something you find enjoyable. But yeah, I definitely.
That was obviously a very good question, Christine, and with my own limited knowledge, I've come to be aware that exercise is absolutely vital.
Yeah.
So, do we have any more? In that case, then, can I thank you very much indeed from us all at Korlipara for having been here, and can we show our appreciation in the usual way?